Okay, so absolute basics of the ECG. Very, very important information that you'll appreciate needing to know. So first and foremost, we begin with the fact that the ECG is essentially a reflection of the electrical activity of the heart. This is all to do with the electrical conductance. Any defects in the wiring of the heart, whether that's due to a heart attack, a thromboembolic event, can also be seen here. Second thing to appreciate, really important, I would say, is that the ECG represents a three-dimensional structure of the heart. Essentially, it gives you a full 3D view, a 360 view of what the heart is doing, in which direction it's pumping, when it's pumping, if there's a bit of a tilt in that pump relative to its axis, etc. The next thing I'm going to appreciate is and remind us that is that this wave here is your P wave. You have your Q wave here, your R wave here, and your S wave here, followed then by the T wave. Okay, so these are all really important. Why? What do they each? What does each mean? Well, the P wave essentially is to do with atrial systole. This is atrial depolarization. When we say depolarization, it means that the muscle is contracting. So this is atrial systole. So the atria is contracting. When does the atria contract? Well, the atria contracts once the SAN, actually the sinoatrial node, remember the pacemaker of the heart located in the wall of the right atrium, sends out a wave of electrical conductance. So therefore one could essentially say that this is where the SAN instigates its whole rhythm. You then get atrial systole, i.e. atrial depolarization. Then there's again, if you recall, going from the SAN to the AV and the atrioventricular node, there is a little bit of time that it takes for it to get across from one node to the other, the AVN being located in the cardiac septum. From there, that will then go down the bundle of His and into the Purkinje fibers of the piney tissue to then cause ventricular systole. Well, that gap, that delay in which it takes for the SAN to get from a SAN to the AV node, the electrical conductance, is represented by this section here. And this is a really, really, really important section because this section is known as the PR segment. The PR segment essentially goes from the end of the P wave to the start of the QRS complex. And this is really important because it actually sets the baseline here. This line here, notice, is in line with this here, which is in line with all of this. This is known as the isoelectric line. And arbitrarily, this isoelectric line is equal to 0. And the reason I bring this into play here at this point is because any deflection that goes up above the line is deemed as a positive deflection, and any deflection that may occur inferior to this line, below the line, is deemed as being a negative deflection. And you'll appreciate the importance of these deflections when you are looking at ECGs and you recognize, say, for example, that there is a lead that was placed on the body incorrectly whilst trying to take an ECG, or in situations when we have, for example, deviation of the axis. These are all things you'll pick up later. Axis deviation may be due to, say, for example, left ventricular hypertrophy, whereby the left ventricle is larger than it should be and therefore pumps harder, and therefore it actually causes a rotation about its axis, the heart's rotation axis, and therefore you get what we call x-axis deviation. Going back to this, the AVN, and so one says, well, where does the AVN? The AVN can therefore be represented from this part over here. So the PR segment represents the isoelectric line. This represents the baseline by which we measure all deflections. And there's another really important factor here. The PR segment becomes important when we are looking at for conditions such as STEMIs. What is a STEMI? Well, a STEMI is an ST elevation myocardial infarction. Again, there are STEMIs. There are various types of heart attacks, and you have STEMI and you have non-STEMI. ST elevation, what do I mean? Well, this section here represents the ST elevation from here to here, this bit all the way there to there. And so what you can have is you can have elevation of this line over here. And so instead of this coming down like this and this staying here, this essentially, and I'll draw it out here, what you can get is that, you'll get that Q, then you'll get the R, and then instead of coming down like this is, what you'll get is you'll get this. So this is your end of your T wave over here, that bit there. This is the end of the R wave here, and this bit here is, so remember that what this should have looked like was down here. There's your S wave, there's your 9, and there's your T wave. Okay, that's what it should have looked like. But what's happened is you've got this elevation of the ST segment, and this is a STEMI, and that's what STEMIs look like. Okay, so that was that. What does the QRS complex represent? Sorry, I diverted a little bit. The QRS complex represents your ventricular depolarization, i.e. your ventricular systole, which is ventricular contraction, and your T wave represents your ventricular repolarization, i.e. ventricular diastole, when the ventricles are relaxing. P wave, atrial depolarization, ventricular depolarization, ventricular repolarization. However, what happened to atrial repolarization? Well, again, if you remember me saying that this is all a representation of the electrical conductance of the heart. Now, we remember that the ventricles are significantly larger than are the atria. And so the electrical voltage that's going to be given off and therefore measured by this machine is going to be greater by the ventricles. So what happens, because the ventricles have gone into ventricular systole in this QRS complex, what's going to happen is that the repolarization of the atria, which is going to be less of a voltage, is therefore hidden inside and under this complex, and it's not seen. So that's what happens there. Okay, moving on. They were the basics there. The PR segment I've already mentioned is the isoelectric line. Why am I stressing that point? Well, because you have this concept over here from measuring from here to here, so the start of the P wave to the end, to the start of the Q wave. This is the PR interval. Okay, not the PR segment, but this is the PR interval. And the PR interval essentially enables us to measure this time that it goes from the start of the SEN to the time it reaches the AVN. Why? Well, again, because if there are delays in this, then that is deemed as being abnormal. So what's really important here to understand is what is the normal PR interval, what is the acceptable range within clinical parameters, and the range is 0.12 seconds to 0.20 seconds. Now if you go back to the basics, you'll recall that each tiny small square on the ECG is worth 0.40 seconds. So therefore you get 3 to 5 small squares is what the PR interval is. Okay, and each large square is worth 0.2 seconds. Okay, so 0.20 seconds, and this is worth 0.04 seconds. Sorry, that's what that should have said. Okay, so you then have, let's delete that. You then have so that's your normal range. Anything greater than 0.20 seconds is equal to what we call AV block, which is otherwise known as first degree heart block, and we'll look at heart blocks in another video. You then have the QRS complex in a similar fashion to the PR interval, given that that has a set range. The QRS complex also has a set range, and the QRS complex should be, let's do it in that, and the QRS complex should be your 3 small squares, no bigger. So it should be 0.12 seconds, and it should be no bigger than 3 small squares. And again, why is that important? Well, this becomes important in situations where you get widening of the QRS complex, and you can get widening in situations when we get something called right or left bundle branch block. Remember, new left bundle branch block in a patient should be investigated because it can indicate an MI in cases. So there you have the right bundle branch block. What is right bundle branch? What is left bundle branch? Very briefly, again going back to the heart, you've got the SAN, you've got the AVN, you've got the bundle of His, the Purkinje tissue or the Purkinje fibers. Well, this bundle of His, when you look at it carefully, is essentially split into the right bundle branch and the left bundle branch, whereby the left bundle branch subdivides into the left anterior fascicles and the left posterior fascicles. And the reason this one splits into the two is because the left ventricle is thicker than is the right ventricle. It is greater amount of muscular component. Why? Again, because it needs to generate a greater force of contraction for the blood to be able to pump around the body. Appreciating the normal circumstances, the P wave should always be a positive deflection, and the T wave should also be a positive deflection. A T wave which is not positive, if it's flattened or if it's inverted, may indicate ischemia, and so therefore we will only ever pick up that in what we call serial ECGs. And that's something again you'll come across later on in live. Serial ECGs, essentially ECGs which are 30 minutes apart, depending on what reference you read. So there you are. That's your pure basics that I think you should absolutely know, and you'll start seeing the application of all this. This is really important. This is really important. That's really important to understand the difference between segmented interval, and really important to understand what each of these components mean, and the fact that there should be positive or negative deflections. And then you'll start applying these understandings in ECGs when you interpret them. Thank you for watching.